Okay, well, good morning, everyone. Thank you very much for the opportunity to speak to you today. My name is SHERINE El-Toukhy, and I'm from the Intramural Research Program at the National Institute on Minority Health and Health Disparities. So the mission of the institute that I work with is actually reducing health disparities and improving minority health. So some of these issues we're talking about are things we wrestle with every day. Today, I really want to highlight lessons that I learned from my own work and my collaborators' work on the participation of underserved populations in digital behavioral interventions, hopefully to inform some of the discussions around the challenges and opportunities of virtual clinical trials. The mandatory NIH disclaimer, I'm funded by NIMHD. I have no conflicts of interest to report, and my views that I'm presenting are mine and do not represent the US government or NIH. So this is an image of how we may think of the disparities gap. And although sections of this gap have been shrinking, others are still crossable. Health information technologies really have been presented as a solution to address some of the deficiencies in the healthcare system in general and to address health inequalities or disparities in particular. However, digital health technologies can also risk exacerbating existing disparities and can create new ones. So in the next few slides, really, I want to highlight several points around access, recruitment, and engagement of underserved populations in digital interventions. So what do we know? These are data from focus group discussions with African American women on their use of mobile phones for health purposes. This was part of formative work for a community-based participatory research for a weight loss mHealth intervention targeting African American women with at risk for cardiovascular disease. So the data basically show that people are attached to their phones. It's health on the go, right? They use their phones for a variety of health purposes, such as interacting with their providers and pharmacies, reviewing their medical records, and also tracking some of the behaviors, such as physical activity through Fitbits. The data is showing that the digital divide is shrinking. So if we look at the top chart, we see that we're almost reaching near saturation point with cell phone ownership at almost 95%, which is the blue line, and then almost 77% for smartphones, which is the orange line. In the bottom chart, we see that this saturation is seen across almost all socio-economic gradients. However, we need to acknowledge that disparities exist. For example, people who are 40 years and older from low socioeconomic backgrounds and unemployed are more likely to own cell phones rather than smartphones. Fortunately, Hispanics or Latinos and Blacks, foreign-born, are more likely to own smartphones. With respect to internet, data from the 2017 National Health Information National Trends Survey, the HINTS survey sponsored by the NCI or the National Cancer Institute, show that roughly 80% report having access to the internet. And means for accessing the internet range from 56% for broadband, 66% for cellular data, and 82% for Wi-Fi. However, again, we find that older age, low socioeconomic status, and being separated or widowed, for example, compared to being married, and not being able to speak English very well are associated with less self-reported use of the internet. We found similar results for when we did similar analysis for accessing patient portals. Socioeconomic status was really the main issue associated with less access to electronic health records. But beyond that initial access, the use of the functions of the patient portal did not really differ across demographic characteristics. So we know that evidence-based behavioral interventions are a promising venue to address social and behavioral factors that underline mortality and morbidity. So these charts show abstinent rates from a text messaging intervention that's publicly available, sponsored by the National Cancer Institute. And it shows the abstinent rates at various time points, the quit date, day 7 post-quit, day 42, which is the end of the treatment for the text messaging program, and then 1 month, 3 months, and 6 month post-treatment. And we see here that abstinent rates are comparable between blacks, shown in yellow, and whites, shown in red. However, for Hispanics, abstinent rates are better when they have completed the intervention, and they're shown in brown. So these are the good news. So what are the bad news? Enrollment in the program was about only 7% for Latinos and about 11% for blacks, well below the national representation for these groups. So what do we do about this? Again, going back to the focus groups that I showed you quotes from earlier, these African-American women that we interviewed basically tell us what to do. So we need to do the formative work, understand the population needs, values, and preferences, what are the barriers for participation. We need to include members of the target population and community stakeholders. We need to design culturally and linguistically appropriate recruitment material. For example, there are websites such as Make It Your Own, will allow you to customize behavioral change messages and recruitment materials depending on the age of the target population, the race and ethnicity, and many other combinations. And then finally, we need to consider where we're recruiting people. So consider some of the promising outlets like churches or schools, and then also modes of recruitment. And finally, we have to evaluate the recruitment efforts. What is the time, cost, and effort versus the yield that we get for recruitment? Finally, engaging participants in digital interventions is very important. We have to engage participants, sustain their engagement, and then re-engage them again. Otherwise, we risk high dropout rates. However, we're not really doing very well on this front. These are data, again, from the text messaging smoking cessation intervention that I showed you earlier. It's targeting pregnant women. And if we see here, these are like the 42 days of the treatment, which is the duration of the treatment. And the green bars show us the percent of dropouts. And basically, we lose more participants in the first week. We lose a lot of participants. I have other data that I'm not showing here, but it also shows a very dramatic drop in response rates to the intervention prompts. So the intervention will send prompts about moods and craving and smoking status, and we see a very, very significant drop in response rate over time. So, however, I'm optimistic. So there is a silver lining here. So the lines at the top basically show the percent of participants who stayed in the program. And if we look, we can see that African Americans in yellow, which is not really yellow now, are more likely to stay in the program compared to whites in orange, whereas Latinos are just as likely to stay in the program compared to whites. So what do we do about engagement? I'd like to highlight 3 points. The first one is basically involve the end users in the creation and design process and prioritize the needs and wants of marginalized populations. The second point is, and many people on the panel have pointed this out, is reduce the burden of assessment. So we want to use passive or automated data collection as possible. And then for self-report measures, there are some novel measurement systems that will allow researchers to use brief and flexible items that capture an underlying construct rather than the fully developed scale, for example, like self-efficacy. And this is just For example, the PROMIS measures are some of these novel measurement systems that I'm referring to. And then finally, we can use some of the adaptive designs to monitor progress using standardized procedures and modify our approach in case of the non-response based on predetermined rules. So this is an example from drug court. You know, what do we do? And basically, we can see some sort of like a step or an escalation in response based on a person is responding or not, or compliant or not. So in the context of a virtual clinical trial, you can think of, for example, if somebody did log their diet, then we don't need to do anything. If they didn't respond, then we can approach them with a different reminder schedule or an incentive structure that will help them adhere to what we want them to do. So I want to end with, this is a paper that we're trying basically to dispel some of the myth around the participation of minorities and underserved populations in digital interventions. They want to participate in research for many reasons, such as helping their communities and contributing to the greater good. Barriers to participation are not as prominent, and they primarily revolved around research value and skepticism. As one participant said it here, it doesn't benefit African Americans if we do not participate. We have to participate. So as researchers, we need to give them the means to participate. We need to move along this community engagement continuum from just outreach activities to really collaboration and leadership, shared leadership approaches to alleviate some of the barriers to participation in research, which will hopefully foster trust as an outcome for the collaboration, which further facilitates future collaborations. So the takeaway points really is that health technologies represent an opportunity to increase participation of minorities and underserved populations in clinical trials. However, we need to address disparities in access, recruitment, and engagement to achieve equitable participation. And thank you very much.